Hi there, I'm the neuromuscular mechanic, and today we're going to be talking about ultrasound guided injections for cervical dystonia with a focus on the sternocleidomastoid and the scalenes. So, what would you use these for? So, you think about what the muscle does. So, the SCM or sternocleidomastoid will bend or flex the head to the same side. So, if you have laterocollis, it rotates the head to the opposite side, so doing it for torticollis. The anterior and middle scalenes will bend the head to the same side, so again for lateral collis. Bilaterally, when they're activated, it'll bend the neck forward, so anterocollis. So knowing what the muscle does, you can think of the indications for dystonia. When we move on to the checklist, like my prior videos, we're going to go through the ideal patient position, what transducer to use, where to start with surface localization, so where to put the probe to start, what structures to identify on pre-scan, and then how do you get after your target. So these structures, generally you can do this sitting. If the patient might be prone for syncopal events, you might do it supine. With the transducer, because these structures are very superficial, you can use a high frequency linear ultrasound probe to get that best resolution. When we talk about surface localization, again, the SCM or sternocleidomastoid, often an easy muscle to palpate. So you take the probe, put it in short axis, roughly around the midpoint of the muscle. Now with the scalenes, a little bit more tricky, but once you've identified your sternocleidomastoid, you can take your probe in short axis, translate more distally, and then if you move posterior from that, you'll visualize the anterior and middle scalenes. And we'll go through that. With your pre-scan, this is where the ultrasound is very useful, because with the sternocleidomastoid, whether you're doing chemodenervation, whether you're doing EMG, you want to make sure that you're avoiding the vessels, so the jugular vein and the carotid artery. With the scalenes, we know that like the brachial plexus, nerves are coming out between the anterior and middle scalene. So we really want to avoid that structure. We need to identify it on imaging, and we'll go through this. With our target, once we find the sternocleidomastoid, you can basically, again, you're having the probe in short axis. You can do the injection in or out of plane. Again, you're trying to avoid those blood vessels. And the anterior and middle scalene, again, do it in short axis, do it often out of plane, and again, you're trying to avoid the brachial plexus. So very important structures we need to avoid with these injections. So we'll start the video now. So I have the probe in short axis. I'm translating basically a little bit medial, and I'm about the midpoint of the SCM or the sternocleidomastoid. And so what we're going to sort of do here is we're going to basically identify some important blood vessels here in a second. And so I've got labeled the pulsatile CA or carotid artery, and then just lateral to it, the collapsible jugular vein. So when we're planning our injection, we need to plan in a way where we're avoiding these structures. So what I'm going to do is I'm going to find these vessels, then I'm going to move my probe, translate a little bit more laterally, again, just showing the jugular vein there collapsing, but I'm going to move a little bit more lateral. So I'm moving lateral. If I pause there, I could certainly do the injection here. If I do it out of plane, I know that even if I penetrate a little bit deeply with the needle through the SCM, I'm not going to get into the carotid artery or the jugular vein. So this is an approach that you can use, short axis, out of plane. Identify the vessels first. That's absolutely critical, particularly the jugular vein and the carotid artery. And again, jugular vein will be collapsible, the carotid artery will not. So that is the sternocleidomastoid. Now what we're going to do is we're going to go to another clip here. Now, so there's my sternocleidomastoid. Now what I'm doing is I've translated distally, and now I've moved a little bit posterior. So again, distal down the SCM, move posterior. And these structures that I've identified in these white circles, those are the nerves from the brachial plexus. And so just keep that area in mind. And if you just sort of follow, you can see those sort of structures moving a little bit anterior, that fascicular pattern of the nerves. And so if we pause there for a second, that is where those nerves are. Again, I've identified it with that white circle. And so that is important because we know that anterior to that and deep to this sternocleidomastoid will be our anterior scalene, or our AS, so that allows us to identify it. Again, we want to avoid the nerves. If we were doing an injection, we could do short axis. And then if I go a little bit more posterior, now posterior to those nerves will be the MS or the middle scalene. So again, those nerves will allow us to identify the borders between the anterior and middle scalenes, but also very crucial to avoid these nerves when we're doing our chemodenervation. And so that is how you can approach these injections. And so that concludes the video series today. I'm the neuromuscular mechanic, and I hope you found today's video series handy. Take care.